medical students and interns who haven't met yet. I've been in Athens for the past month and a half, so it's good to be back here at Erlanger giving this talk this morning. Today we're going to talk about continuous renal replacement therapy, or also known as CRRT in the ICU. It's a topic that's pretty unique to our program, in that it seems like we may be the only surgical program in the country that implements and initiates CRRT and manages it in their surgical and trauma patients. So an outline of our presentation today, we'll go over a brief case presentation. We'll talk about acute kidney injury in the ICU. We'll go over continuous renal replacement therapy, what it is and the different modalities. We'll review some surgical and trauma literature regarding CRRT patients. We'll go over some data excuse me, that we have here at Erlanger regarding our patients, and we'll go over cost of medicine. So first, we had a 45-year-old male who presented as a level 1 trauma after being found down. He presented as a GCS of 14. He had a history of seizures and had been off his medications for over a year. He presented with multiple abrasions and bruises throughout his body. He had past medical history of depression and seizures. He took no medications for these. On physical exam, he had multiple small lacerations to his head. He had diminished breath sounds on the right. He had multiple contusions and to his back and pelvis consistent with chronic falling. He presented with vital signs of blood pressure of 84/46, or heart rate of 91, and a temperature of 96.4. His labs are listed here. You can see he presented with a BUN of 33, creatinine of 2.8, and a lactate of 4.9. So he was admitted to the ICU overnight, and the following morning on hospital day 1, his CPK was found to be over 63,000. He had a creatinine of 3.3, and he was anuric. So right IJ VAS cath was placed, and CRRT was initiated by the surgical critical care service. On hospital days 3, 4, and 5, he remained on CRRT, but his urine output gradually improved. His creatinine on hospital day 5 was 1.7, and he was making good urine, so his CRRT was stopped and nephrology was consulted for further management. He remained in the hospital from days 6 to 14. On hospital day 6, he was transferred to the floor, and on the floor he received intermittent hemodialysis by the nephrology service. He ultimately required a perm cath placement and was discharged on hospital day 4, set to receive intermittent hemodialysis as an outpatient in Fort Payne, Alabama. So this was deemed one of the success stories of our CRRT. As you'll see, the mortality rates on critically ill patients can range from 40% up to 65%. So we'll go over that a little later. A little bit about acute kidney injury in the ICU. It's a common diagnosis and associated with significant morbidity and mortality. It affects up to 5 to 10% of hospitalized patients and up to 60% of patients in the ICU. It's been found in several studies that it can affect 12 to 36% of trauma admissions. It's characterized by the accumulation of creatinine, urea, and other unmeasured waste products. There's been several classifications and definitions of acute kidney injury. We're more familiar with these first two. This first one stands for kidney disease, improving global outcomes. They published a consensus on their classification of acute kidney injury, and it's greater than 3 milligrams per deciliter absolute increase of creatinine over a 48-hour period, or 1.5 to around 2 times the baseline creatinine, which is similar to the classification of the acute kidney injury network. So when you have a patient with acute kidney injury, the workup involves history and physical exam, a medication review, assessment of their hemodynamic status and volume status through arterial lines, central lines, Foley's to monitor the urine output, and we'll often get urine indices as well. I know this is a busy slide, but this kind of just depicts there's a wide range of causes of acute kidney injury. They're typically broken down into pre-renal, renal, and post-renal causes. Most of the patients that we will see is likely due to a pre-renal cause, either hypovolemia from hemorrhage or systemic vasodilation from sepsis or SIRS, but as you can see, there's a wide range of causes of acute kidney injury. On the topic of fluid status and hypovolemia, IV fluid resuscitation should be used judiciously in those with AKI who are not volume responsive. Administration of IV fluids in sepsis and hypovolemia can be beneficial initially, but fluid overload can be detrimental. And in a large multi-center cohort that was focused on critically ill patients, they found that those with fluid overload or a 10% weight gain at the time of renal replacement therapy initiation had an odds ratio for death of 2.07. So patients with severe AKI may develop hyperkalemia, metabolic acidosis, volume overload, and signs and symptoms of uremia. And despite temporizing measures, some will ultimately require renal replacement therapy. So when we talk about renal replacement therapy, there's two different modalities: intermittent hemodialysis and continuous renal replacement therapy. To date, there's been small randomized clinical trials and meta-analyses that found no association between modality and mortality or renal recovery. However, with that being said, CRRT has been the modality of choice in those that are critically ill and hemodynamically unstable. A little bit about the history of CRRT. It was first developed in 1977 when a doctor named Dr. Kramer was introducing a vas cath into the femoral vein before initiating hemodialysis and accidentally inserted the catheter into the femoral artery. He then realized the possibility of utilizing the arteriovenous gradient for filtration of blood and fluid elimination, and he replaced the excess fluid loss by continuous infusion of substituting fluids. He coined this method, continuous arteriovenous hemofiltration, and over the past 30 years, this idea has been further modified to the CRRT techniques that we utilize today. So what is CRRT and how does it work? Well, first of all, it involves vascular access, so we're all familiar with this. This is a vas cath, and it's a blood purification technique that harnesses the inherent principles of supportive kidney function to achieve solute and fluid homeostasis, and it's intended to be applied for 24 hours or longer. It removes solutes through the principles of diffusion, convection, and ultrafiltration, which we'll touch on the next slide. And it allows for slow and isotonic fluid removal that results in better hemodynamic tolerance in those that are critically ill and hemodynamically unstable. So these are several principles that CRRT employs. The principle of diffusion, which is the movement of solutes through a semipermeable membrane from an area of higher concentration to an area of lower concentration. In CRRT, the diffusion occurs when blood on one side of the membrane and dialysate solution on the other side of the membrane. There's another principle of ultrafiltration, which is the movement of fluid through a semipermeable membrane along a pressure gradient. So you have a positive pressure on one side and a negative pressure on the other side. And then along with the principle of ultrafiltration is the principle of convection, which is the one-way movement of solutes through a semipermeable membrane with the water flow of ultrafiltration. So there's several different CRRT methods. There's a slow continuous ultrafiltration, or SCUF, and it just utilizes the principle of convection for a slow removal of fluid. There's continuous veno-venous hemofiltration, or CVVH, that utilizes convection for the removal of solutes and fluids. There's continuous veno-venous hemodialysis, which utilizes diffusion for removal of solutes and fluid. And then there's continuous veno-venous hemodiafiltration, or CVVHDF, which is the modality that we use here for solute and fluid removal. So like I said, CVVHDF is the mode that we use here. It utilizes the principles of diffusion and convection, and it requires a dialysate fluid and a substitution fluid. And it's effective at removing small, medium, and large molecules, and also for fluid removal. This is the CRRT machine that we have here. It's the Prismaflex, and at first glance it may not seem that complicated, but there's many ins and outs to this machine, and it's one of the reasons why we send our critical care fellows down to get trained in this is because it can be quite complex. Some of the indications for CRRT, there's not a set guideline or algorithm. It's really physician discretion of when to use it. But some of the indications are uremia, fluid overload, metabolic acidosis, electrolyte abnormalities such as hyperkalemia, removal of toxins and drugs, temperature control, and rhabdomyolysis like we had in our trauma patient for our case presentation. There's several topics for hot debate on CRRT, indications being one, and when to initiate and timing being another. There are several trials that and studies that had contradictory outcomes. The Lane trial, early versus late initiation of renal replacement therapy, found that 90-day mortality was significantly lower in patients randomized to earlier CRRT. But on the flip side, the artificial kidney initiation and kidney injury was a multi-center trial that did not find a significant difference in mortality between early and delayed renal replacement therapy. So the question of whether early renal replacement therapy is beneficial, and if so, which patients, remains vastly unanswered. And also on the topic of discontinuation, there's really no prospective evidence or data of when to stop it, but the decision to stop it can be made based on one of three clinical scenarios. Either the intrinsic kidney function has adequately improved, the disorder that prompted the renal support has improved, or continued renal replacement therapy is not in line with the goals of care of the patient anymore. There's been one study that found urine output is a good predictive measurement for successful discontinuation. One study found that 24-hour urine output of greater than 400 milliliters in patients not using diuretics was associated with greater than 80% chance of successful discontinuation. So let's go a little bit about the literature on CRRT. There's a good bit amount of literature on in the medical journals on CRRT, and they group all the patients together, whether they're surgical, trauma, or medical patients receiving CRRT. So here's 5 studies that I found through a literature review ranging from 2009 to 2017, and these were all patients, and their mortality rates range from 45 to 63.5%. So we'll go over some literature regarding CRRT in just surgical or trauma patients. So this was published in 2007 in the American Journal of Surgery. It was titled 90-Day Mortality and the Subsequent Renal Recovery in Critically Ill Surgical Patients Requiring Renal Replacement Therapy. This was conducted in Taiwan in 4 hospitals with mixed postoperative patients in their ICUs. It was conducted in 2002 to 2006, and they set to investigate any predictive factors for mortality or renal recovery in those undergoing RRT. So they had a total of 342 patients. 137 of their patients survived, 205 of them died, so they had a mortality rate of 60% in their ICU patients. And this top table looked at independent predictors of 90-day mortality, and so they found that things like sepsis, if the patient required CPR, CRRT report, higher SOFA scores were all independent predictors for mortality in their patients. This bottom chart here was independent factors for renal recovery, and they found that lower SAPS-2 scores and CRRT use was associated with, it was an independent factor for renal recovery. This next study was done at Cornell and was published in the Journal of Trauma. And at their institution, CRRT was implemented in 2001. And so they hypothesized that renal recovery and mortality rate would be lower in those patients that underwent CRRT versus beforehand, those patients just underwent intermittent hemodialysis. So They compared patients from 1994 to 2001, and that was their pre-CRRT group, and then they compared it to the patients from 2001 to 2004, their post-CRRT group. And also of note that all of the orders were written by either a consultation service, so they didn't manage their own renal replacement therapy. It was the nephrology service that ordered theirs. So what they found was that their mortality rate was about 45 or 46%, but there was no difference between their two groups, Group 1 being the pre-CRRT group and Group 2 being the post-CRRT group. They didn't find any difference in mortality, but they had a rate of about 45%. This next article was published here recently in JAMA Surgery, and they looked at the analysis of survival after initiation of CRRT in the surgical ICU. So they hypothesized that there was a duration of CRRT beyond which it's futile for the patient. So what they did was they looked at all of their patients in their surgical ICU that underwent CRRT from July 2012 to 2016, and their ICUs were consistent of trauma, general surgery, GYN, urology, orthopedic surgery, vascular, and they also included, to power their study, hepatobiliary patients that were awaiting transplant. So what they looked at, their primary outcome was survival to discharge. So we'll focus more on this left side here because this is their general surgery group. This is their pre-transplant group. They had 53 patients in their surgical ICU that underwent CRRT, and as you can see here, their mean age was 67. Their BMI was probably quite a bit lower than what ours is. It's 25, and about 37% of their patients had underlying CKD. And so what they found was that the only statistically significant factor for mortality was duration of CRRT. So they grouped their patients into three different groups: those that underwent CRRT for 1 to 3 days, those that had it for 4 to 6 days, and those that had it for greater than 7 days. And what they found was that the mortality rate for those for 1 to 3 days was about 38%. The mortality rate for those undergoing CRRT for 4 to 6 days was about 57%, and those undergoing CRRT greater than 7 days had 100% mortality in their groups. And this similar Kaplan-Meier graph showed here, none of their patients, this orange line, none of their patients undergoing CRRT for greater than 7 days survived for discharge to hospital. And this last study here was out of shock trauma, and it was published in 2006, and it was basically just an observational study of their CRRT program and what they do. And so they had a period of from 1980 and 1987 that they just implemented CAVH by medical intensivists and intermittent dialysis by nephrologists. And then from 1987 to 2000, they implemented the different modes of CRRT that we mentioned earlier by the medical intensivists, and then intermittent dialysis by nephrologists. And then from 2000 on, they implemented sort of a collaborative approach between the intensive care program that they have along with their academic nephrology program. So they kind of manage their patients jointly. So what they found was their mortality rate in patients requiring CRRT at shock trauma decreased 13% from 67 to 58 in the following year after instituting their multidisciplinary approach. And they quoted that mortality rate in surgical trauma patients can be up to 50%. So a little bit about our CRRT program and how we're doing here. CRRT was first implemented here at Erlanger in 1999. We implement and initiate CRRT in our ACS trauma patients, and it's implemented by our critical care staff. We send our fellows to a CRRT course at UAB, and we often consult the nephrology service once CRRT is stopped and if the patient needs intermittent dialysis. So there was a study that we published years ago. Dr. Waldrop, whenever he was a resident in 2005, published in the American Surgeon titled "A Comparison of Continuous Renal Replacement Therapy to Intermittent Dialysis in Acutely Ill Surgical Patients." And so what he did was he looked at 27 patients from 1997 to 2009 that underwent dialysis by the nephrology service, and he compared it to 30 patients from 1999 to 2002 in which they underwent CRRT performed by our ACS and critical care staff. So what he found was that here the duration was about 15 days versus 20 days. There was really no significant difference in survival, 46% and 40%, but what they found was that about 55% remained off hemodialysis if they underwent CRRT versus only 37% here remained off of any kind of dialysis if they underwent intermittent hemodialysis. So with that being said, there's a lot of literature on medical patients and surgical patients. There's not a whole lot published right now on CRRT and trauma patients. And since so we have the trauma registry, we're starting to look at our trauma patients on CRRT. And so we've looked at from 2007 to 2017 with the inclusion criteria of patients greater than 15 years of age and just trauma patients that underwent CRRT. And we did not exclude anyone younger than 15. We didn't include any patients requiring dialysis before their traumatic incident. We didn't include any patients that underwent dialysis by the nephrology service. So far we've accrued a total of 45 patients, and our mortality rate here has been pretty good. It's been 31%. And here's a little bit more about our data. Our average age was 46%, and with 82% being males. Average length of stay would be about 25 days in the ICU and 31 days in the hospital, and only 44% of the patients had a need for further dialysis. So I think it just bodes well to our program here and what we've been doing. It's pretty unique in that seems to be the only surgical program that gets training on managing our own CRRT patients. And so a little bit about cost of medicine. The PrismaFlex CRRT machine has a list price of about $20,000, and a filter for the CRRT costs close to $360. Be happy to take any questions.
How long have our patients been on CRRT?
The average days I think we had was 9 days.
All right, and the patient that you used as your case study here, rhabdomyolysis.
Yes, sir.
Cause for renal failure.
Yes, sir.
And the reason he's still on dialysis is that he sustained a injury that has put him into chronic mode.
Right, and it was difficult to ascertain from going back and look at paper charts. I could just tell that he was discharged and he was going to receive intermittent hemodialysis as an outpatient. I don't know if he ended up fully recovering or not.
Appreciate you taking on that topic. It's kind of bland, but it's really important in the critical care arena. The reasons why CRT, I think, has potential benefit over just intermittent dialysis, you kind of touched on this, but I'll go into a little more detail, is the fluid shifts that you get with intermittent hemodialysis can lead to hemodynamic instability in the critically ill. And if you make somebody hypotensive that has acute kidney injury, then you're just propagating kidney injury. And so this slower dialysis over a 24-hour period of time, you can reduce the amount of volume shifting that you're going to see. And so it's a gentler modality, I think better tolerated by the critically ill. The reason why I think it's beneficial for surgeons to do this, are there any nephrologists in the room? because nephrologists just do not conceptualize volume like surgeons do, and they think everybody is volume overloaded and they can be on 2 pressors and they can still be trying to pull fluid off these patients. And we have seen a number of examples of where they have caused dead bowel in patients that they are just hammering with fluid removal. They'll be on the pulmonary critical care service and they'll just be dialyzing the hell out of them, and then they'll go into metabolic acidosis and have a distended abdomen and call us, and I'm like, God damn, they've done it again. And I'd sit down in a room and discuss this with them because it has been a serious problem. So surgeons understand the volume balance in their patients so much better than nephrologists. We can relate volume status to what's going on in the lung, and we just have a better concept of how the patient is doing and how they're going to respond to what dialysis modality that we're going to use. So the other thing about CRT is the dose. There was some sensationalism back around 2003 to 2007 in Europe. They were talking about, dialyzing cytokines off of patients with these ultra-high doses. That the PrismaFlex, you can run a dose of about 9 liters an hour, which is way, 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 way more than anybody ever needs. And so there was some preliminary evidence that you could improve the survival in a septic patient by just giving them these ultra-high doses, and some standardized studies came along and showed that that was not the case. And the case now is controlling your dose to 25 to 30 cc's per kilo per hour. And if you go over that, you don't know what you're doing to your medications. The residents are probably used to hearing me preach this on rounds. You don't know what you're doing to your antibiotics. You don't know what you're doing to your beta blockers, your amiodarone. You don't know what you're doing to any of your medications, because no one really understands the volume and distribution of all of these intravenous medications while somebody's on CRT. Just the pharmacist doesn't understand it. They can check levels and try and adjust doses, but you go up in the unit and patients that aren't on our service, I'm trying to say this as politically correctly as I can, but their doses are 3 and 4 times what they should be, and a 5-liter bag of Prismasate costs $22. So they can be driving the cost way, way up by overdosing. They don't know what they're doing with any of their medications, and it increases the nursing workload tremendously. They got to haul all that fluid in the room, and then they got to haul it all back out. So, and that's one of the reasons why we send our residents to the CRT Academy, because they really stress the dose thing down there. I mean, it's a great
dose of medications, or
no, the dose of CRT,
okay.
how much dialysate and how much replacement fluid that they run. That's a great course. We could do lectures here, but it's such a concentrated experts in the field, and it's cheap, close, and been very beneficial. All the faculty have gone there. It's anybody interested.
What is our approach in terms of initiation? I assume it must be early.
Yes.
Early in the course, as opposed to the late.
Yes.
Because a lot of the data that Brent talked about seem to talk a lot about that.
There's been a lot of hype about early improving outcomes. I think that's still a very controversial area. If early initiation improves it, you talk to some people and they get reverent about that.
What are our, if you had any rigid criteria, what would they be?
Somebody that goes in is anuric.
Okay. Anuric's one. Okay.
Yeah, and
what about if they have 10, 12 cc's an hour?
We might follow that patient.
Okay. So you treat it more.
We might give them some diuretics.
Fluid balance and other means to support it then.
Yeah. If they're not on pressors, we might give them a trial of diuretic. There's really no harm. There's been no proven benefit.
I guess my point is, do we start it on people that are making water but not?
Yes,
yeah,
we
okay.
would.
So
yeah.
a creatinine increase of the 0.3 was that what you said, 0.3 in 24 hours, or?
That's the stage 1 of AKI is where
Yeah. We would look at the global picture. Is this patient 70 years old?
So
Do they
it's
have?
a multi-dimensional decision
Yes,
about
yes.
when to put somebody on it. Now, what about this issue of leaving them on more than 7 days? I mean, what do we think about that?
I don't know if any of the other faculty would care to respond to that. We personally haven't seen it.
You've not had, I thought we had some people that have been on it longer than that who've survived. I mean, there was 100% mortality.
We'll spend CRT for days and days and days.
That's what I thought.
It doesn't bother us to go past 7 days, 10 days, 14 days, however long they need it. We initiate based on etiology. We'll check pre-renal states, we'll check renal states, and if we think it's going to be a gradual, slow worsening, we'll start early. If we think it's something we can turn around immediately, then we'll try the diuretics and fluid. But yet to run a CRT for 2 weeks doesn't bother us at all. We'll see a higher rate of maintaining dialysis with that, but I don't think we see a higher mortality that everybody's preaching here. That just doesn't seem to happen.
Sounds like we need to put our data together compared to some of what you've mentioned there. Dr. Moore?
I can appreciate passion, without a doubt, but it appeared to me that at least in some of the earlier studies, the average age was 65 or something. Your average age is 45. And at one point you presented some data that said that if you took and shook them all out, they were going to have the same mortality. Is there anybody running any studies currently on these younger group that are specifically trauma patients on whether you're still going to have 38% mortality?
No, sir.
So it's lower, it would have been the same?
Not a whole lot of literature on just trauma patients. Most of them either group all their patients together, medical, surgical, or they sort of separate trauma and surgery like this other study that they had. They grouped GYN, vascular, cardiothoracic, they grouped all their patients together. Hasn't been a whole lot of just trauma. And so I think part of the reason why maybe our age range is so low is because trauma patients sometimes tend to be younger. So our average age was 45 versus some of these other studies were grouped all comers, which may contribute to the age differential.
More likely you're going to die.
What your shock trauma paper that you referenced, I guess I missed at the end. What was their take-home?
This was more of just an observational study of just what they did. I think what the main thing was when they implemented this collaborative approach, instead of waiting on the nephrology service to implement things or waiting on the medical intensive service to implement things, when they had more of a collaborative approach, their mortality rate decreased.
So working together is a good idea. Well, that was any other questions or comments? I guess I would have to say one, since Dr. Maxwell's already opened the floor for debate. Let me just say that for the medical students here, that there's one definition, that the good surgeon is an internist who has finished the training. And so this does involve a lot of metabolic, the use of your understanding of physiology and the treatment of metabolic problems. And so that was why we got into the CRRT before, because we didn't have really anybody, frankly, in any other disciplines here who wanted to do it, and yet we thought it was something we really need to get involved in. Go ahead, Bob, now.
Adsorption, myoglobin and hemoglobin stick directly to the filter, and so when you have somebody that has myoglobinuria or has had hemolysis, you have to change the filter after about 4 to 6 hours. Just go in the room and look at it, and you can see the filter get coated with the molecules, and the filter won't work anymore, and it'll stop removing those particles.
It's too big to pass through.
You what?
It's too big a molecule to pass through the membrane.
Yeah, okay. All right. Okay, let's go on to our next case.
All right, I'll go ahead and get started. So today I'm going to talk about a trauma case that I had the privilege of participating in with Dr. Hunt. First, we'll present the case, talk a little bit about penetrating cardiac trauma. Obviously, there's a whole lot to talk about in that regard, and so this is a relatively narrow net as far as that's concerned. But we'll talk about just an overview, a historical perspective, the initial evaluation, the trauma bay, any adjunct studies that can be performed, and operative management. We'll talk a little bit about how the patient did after, of course, discuss cost of medicine, and hopefully have time for questions at the end. So this patient presented as a level 1 trauma activation. He's a 22-year-old male who sustained a knife stab wound to his left lower precordium, basically right to the left of his upper xiphoid. Initially, the patient had increased work of breathing and hypoxia when he arrived, and so the patient was intubated in the emergency department. After that was done, he had bilateral equal breath sounds and had 2+ radial pulses. He was diaphoretic. Initial vital signs demonstrated that he was normotensive but tachycardic, and once he was intubated on 100% oxygen, his saturation was 100%. On secondary survey, the patient had one traumatic injury, again a 2-centimeter laceration just to the left of the upper aspect of the xiphoid. The patient had a fast exam performed, which demonstrated some pericardial fluid as well as some thrombus present within the pericardium. Given this, the patient was taken emergently to the operating room for exploration. So intraoperatively, a median sternotomy was planned and performed. Pericardium was opened after that, and traction sutures were replaced. We immediately encountered sanguinous fluid. We were able to localize a 1.5 centimeter laceration to the right ventricle. Digital pressure was held to this to provide temporary hemostasis. This was closed with 3/0 proline suture in a horizontal mattress fashion with pledgets, requiring 2 sutures, and we had good hemostasis after that. We checked to ensure that the trajectory of the knife didn't enter the peritoneal cavity, and it didn't appear that there was any evidence of peritoneal violation. Anesthesiology actually performed a transesophageal echocardiogram while we were in the procedure, which I wasn't able to get the images, but it didn't indicate that there were any valvular issues that they saw, and no wall motion abnormalities or anything like that. The laceration was around the distal branch of one of the coronary vessels, and so we did attempt to place the suture underneath that vascular bed in a horizontal mattress fashion, which we'll talk a little bit more about. We left a 28-French mediastinal drain in place, and then post-operatively a chest X-ray was obtained in the OR still, which demonstrated the patient had a right hemothorax, and so we placed a 32-French right chest tube at that time. All in all, the patient was initially started on master transfusion protocol. He received 4 units of whole blood, 1 unit of packed red blood cells, 3 units of FFP, and a 6-pack of platelets and 1,100 milliliters of cell saver. Patient subsequently was transferred to the intensive care unit. He remained intubated, but was hemodynamically stable, actually on a little bit of cardine when he left the operating room. So historically, I found this kind of interesting reading over. I found a couple of interesting articles that talked about this. So cardiac trauma, some of the first descriptions of this occurred in the Iliad by Homer, and throughout history. And it was kind of uniformly thought to be a fatal condition until the 17th century. In the 17th century, some case reports by Wolfe and Torby indicated that some old cardiac injuries were found that people died from other reasons, and on autopsy these were found, notably in a deer and then actually in a human slightly later than that. And so this raised the idea that, you know, these injuries could be survivable. So in 1761, Dr. Morgani, who the Morgani hernia is named after, described tamponade physiology as a result of cardiac trauma. And in the 1800s, people started discussing, well, you know, if these types of injuries can heal, you know, what can we do to try to help these people survive these types of injuries? And so Drs. Romero, Leray, Purple, and Fisher all pioneered performing basically a pericardial window and leaving a drain to alleviate cardiac tamponade, and did have a couple of patients survive. Dr. Romero was the first patient to actually have one that lived long term. A lot of times these patients would end up with median stenotis. Despite some operative successes, repair was still considered controversial. Notably, there were several quotes from Dr. Billroth in 1883 about the futility of performing cardiac surgery. The first successful suture cardiography was performed in 1895 by a German surgeon by the name of Dr. Rain. This patient was a 22-year-old male lifeguard patient who received a knife stab wound to the left chest. He underwent a left anterolateral thoracotomy with fourth rib resection. And they found a hole in the pericardium, opened this, and found a hole in the right ventricle, which they repaired with silk suture. And the patient actually survived from this and was discharged from the hospital. There were a couple of other surgeons prior to this who had attempted this repair, and those patients did not survive. So he's kind of credited as being the first person to actually have a successful cardiography. So talking about penetrating cardiac trauma, there are kind of two wings to cardiac trauma. There's blunt and penetrating, and you know, the initial evaluation and management is very different in these. Penetrating cardiac trauma represents 1% of all penetrating trauma. 60 to 80% of patients are cited to be deceased at the scene. And the mortality of all comers who arrive to the ER with signs of life is somewhere between 19 and 73%, depending on who you read and what the nature of the injuries were. Historically, 80% of penetrating cardiac trauma has been knife stab wounds and about 20% ballistics, but more recently that started to equilibrate a little bit more. We've seen more ballistic trauma. So with the increased incidence of ballistic trauma, we have seen an increase in multi-chamber injuries, which makes sense. And so lots of groups have looked at the survival between an isolated injury and a multi-chamber injury, and the single-chamber injury patients tend to do better. So the multi-chamber patients usually have about a 25% or a 75% lower survival rate from the single-chamber patients. As far as looking at the incidence of injuries, anatomically, the right ventricle is the most commonly injured just because of where it lies. And this is talking about just single chamber injuries. Left ventricle about 25%, and then right atrium 10%, and left atrium 1%. And then if you look at the mortality of each of these and just single chamber injuries, right ventricular injuries about 60%, left is 40%. And the right atrial and left atrial are about 30%. There's probably some bias here because of how common the right ventricular injury is compared to some of the others. There are several independent predictors of mortality that have been elucidated. Time from injury is important, which plays into the next factor, which is the patient's physiologic status. So if the patient's in extremis or has arrested and you're performing a resuscitative thoracotomy, then clearly the patient's going to have a worse, higher likelihood of mortality. Single chamber versus multi-chamber injuries. So single chamber injuries have a lower mortality than the multi-chambers we've talked about. Stab wounds versus ballistic injuries, because of the single chamber versus multi-chamber, you're more likely to have multi-chamber, and a blast injury is more likely to have other contusion and localized trauma as well. Anatomic characteristics as well. So not just if you have multi-chamber injuries, but also does this involve proximal coronary artery? Is there a valvular injury? Is there a great vessel injury? All of those things increase the mortality. And then actually the presence of tamponade physiology versus hemorrhage does bode a lower mortality. So actually tamponade physiology, if that's present, is preferable to, obviously the patient's hemorrhaging into their chest. So as far as assessing this patient, you have to think about the timing of the injury and the timing of the cardiac arrest. A patient who's been arresting for greater than 15 minutes prior to arrival has a much lower chance of success with a resuscitative thoracotomy. It's about 1.5% survival. Obviously, looking at the ABCs, look at the breath sounds. If the patient has evidence of, tamponade physiology, there could be a possibility the patient has a tension pneumothorax or something like that needs to be taken care of, or hemothorax. And so it's important to evaluate that. Look at the location of the injuries. If you've got one wound on the left side and the right side, and you think you have a transmediastinal gunshot wound, that can be different as opposed to, if you have a single stab incision elsewhere. And to that end, we're evoking the cardiac box, which is basically if you have a patient that has trauma in this area, so from the clavicles down to the xiphoid, and then from areola to areola, this is the area of concern for possible cardiac injury. And that includes the patient's back as well, so it's more of a cylinder. So they've generated this three-dimensional cardiac box, but you can kind of think about it that way. Presence of tamponade physiology, again, we kind of talked about why that would be, and so here we'll talk about what Beck's triad is. So hypotension, muffled heart sounds, and JVD. This actually is not, these are not all three present in up to 75% of patients who have tamponade from penetrating cardiac injury. But classically, these are the things that you would look for there. And then a chest x-ray can be helpful to, elucidate if you've got a large hemothorax or pneumothorax that needs to be taken care of, and also seeing how the trajectory of the missile was. CT scan can be useful, obviously, in a stable patient, and shouldn't be performed prior to transfer if you need to move the patient to a higher level of care. And because of cardiac motion, it's not as useful as it is for other anatomic areas. Pericardial window is kind of the gold standard to evaluate if you've had a cardiac injury. And so if you suspect this, you can perform a pericardial window and evaluate the patient for clot or blood within the pericardium, and that will let you know if you need to proceed further. But ultrasound recently has kind of taken the place as a less invasive manner of evaluating if there's blood in the pericardium. So there's a paper out of Annals of Surgery in 1996 by Dr. Riziki out of Emory, where she looked at ultrasound compared to pericardial window and evaluating CVP and the cost, time that needed to be performed, and in a well-trained person, how accurate these studies were. And essentially, ultrasound was found to be close to 100% accurate, and takes 0.8 minutes as opposed to 30 to 40 minutes and costs significantly less if your hospital is invested in ultrasound. And so that's kind of ushered in the use of ultrasound as a modality to detect this. And so what you would see is this is a subxiphoid window, so you would take the ultrasound probe up under the xiphoid. This is the liver parenchyma here, and you can see the heart over here. And so the pericardium is this white line here, and then you've got your right ventricle and your left ventricle, and you can see this fluid here, and you can see more echogenic focus if there's thrombus there. So if you were to find a positive hemopericardium on a fast exam, and that's indication to take the patient to the operating room for exploration. So in our patient, we proceeded with a median sternotomy. If the patient's receiving a resuscitative thoracotomy, then you would proceed through a left anterior lateral thoracotomy. You try to initiate local control. You can use a finger to try to plug the hole, or Foley catheter with a balloon. Skin stapler has been used. And then perform a laceration repair with non-resorbable monofilament pledgeted suture, preferably, typically in a horizontal mattress fashion. Again, if the coronary artery is juxtaposed to your injury, you want to try to place your suture underneath the vascular bed to attempt not to ligate the vessel. A distal coronary artery injury could be ligated. More proximal injury with ligation, would result in acute ischemia. So generally, it's recommended to try to repair that if you can. And to that end, CT surgery and cardiopulmonary bypass may be necessary for complicated injuries, multi-chamber injuries, valvular injuries, great vessel injuries, or coronary artery injuries. Postoperatively, echocardiogram is recommended to evaluate the patient to ensure that there's no valvular injury, septal injury, make sure there's no aneurysm or anything like that may be forming in the future. And if your goal is to initially stabilize these patients in the acute setting, and then if they do have one of these other injuries, a lot of times these can be repaired a little later on. So here's a picture, because this was the first time I'd done a cardiorrhaphy with pledgeted suture this way, and so this isn't a picture of our actual patient, but this is essentially the kind of repair that we did. And so you can see the horizontal mattress thrown through the pledget and about to be tied down to try to close this laceration here. Postoperatively, our patient did well. He actually was extubated a few hours after he came back from the operating room the next morning. He had an echocardiogram the next morning, which didn't demonstrate any valvular or other abnormalities, and no large hemopericardium. Postoperative day number 3, the patient's mediastinal tube was removed. The patient was found to have a persistent right hemopneumothorax despite the right thoracostomy tube that we placed. We attempted to reposition this tube, and eventually the patient underwent a videoscopic decortication of his right chest, and another chest tube was placed. And postoperatively, day number 1 from that, that was noted to not really be draining very much, and the patient's lung was up, and so that chest tube was removed. The patient was discharged. He came back to clinic last month and was doing very well. So from a cost of medicine standpoint, we used the Pioneer cable system to close the patient's sternotomy versus the standard sternal wires. I looked up the cost of these and the benefits, but for those of you that haven't used this system, because it was the first time I'd used it, basically what it is if you look at this picture here, you pass the cables through around the sternum, and then they go through basically a little piece of metal that can crimp down and hold tension that you've put on the wires. And then you adjust tension on your cables up here at the apex of it, and then you'll crimp it once you've got adequate tension. So the thought of using this system is it'll allow you to, there's a gauge basically, you can put uniform tension on all your cables, and the cables are a multi-filament as opposed to kind of a monofilament sternal wire. So they have up to 10%, 10 times greater tensile strength. And so because of this, many people have adopted this cable system as well. Here are my references, and I'm happy to take questions.
Have questions, comments about this? Yes? Yeah, here, Dr. Smith.
I do have one comment. That is, the simple fact that skin staplers have been used doesn't make them the thing to use. They tear the muscle. Put your finger on the hole, go upstairs, keep your hand in his chest. I had a friend who was over in Afghanistan during the recent war, and the British sent him somebody who they closed their colon with skin staples, and believe it or not, that didn't work. So just because somebody's used it, please don't say that's the way we do things. If you're opening a chest, you ought to have a suture somewhere in your near vicinity.
Bob, you want?
Agree with Dr. Smith more about how to manage a hole while you're trying to get somebody to the operating room like that. Is put your finger in it. The Foley catheter is just going to rip the inside of the heart up. Doesn't work. And the stapler thing's an idiotic idea to do that to the heart, in my opinion. Just put your finger in it and get to the operating room as fast as you can. I thought it was interesting that you highlighted the first cardiography was performed with a silk suture. We go through all sorts of machinations and debates about what kind of suture we got to use, and you know, a simple silk will work. And I'll go into an anecdote. It's a favorite anecdote of mine. When I was a trauma chief, one of my faculty criticized me for opening the intercostal muscles with curved Mayos. He told me if I was going to be a trauma surgeon that I needed to use a scalpel to open the intercostal muscles. So the next ER thoracotomy I did was for a gunshot wound to the abdomen, and I used a scalpel to open the intercostals, and I cut the heart when I was getting into the chest. And once I got the heart beating again, it was obvious because there was blood squirting out of it, and I'm going, oh shit, I'm going to get in trouble for this. And I'm like, well, how am I going to deal with that? And in this trauma bay, we didn't have a lot of fancy stuff, and I was just like, give me a 2-0 silk suture, and I stitched the heart up with that, and we took the patient to the operating room, and then I had to explain myself that I had cut the heart when I was getting into the chest. So you can use silk, and it works. One other digression I'll make is about how ER thoracotomies came into being. It was actually two institutions were kind of simultaneously but independently started doing the first ER thoracotomies. I think the first published data was out of Baylor. DeBakey's fellow, I guess, used to take call in-house, and when they had, prior to the ER thoracotomy, if you had a penetrating precordial wound, they just put you in the hospital and just wait to see how you were going to do. There was, you know, kind of crazy back then. People were, weren't expecting anything like that, and he reported his data a couple of times, and Anna Ledgerwood and that crazy colleague of hers, Lucas, also sort of developed ER thoracotomy, started in the early 1960s, and now it's become standard of care across the country. One final comment, and I'll shut up. That's not Beck's triad. Do you know who Beck was?
He was a cardiac surgeon. He did.
I think he was a medical doctor, ran an infirmary, and they had a bunch of people with renal failure and uremic pericardial effusions, and it's not hypotension, it's pulsus paradoxicus. It has gotten promulgated to hypotension over time, but he had a bunch of people sitting around, and he checked their blood pressure while they're breathing in and breathing out, and they discovered that patients who were developing impending cardiac tamponade had pulsus paradoxicus, And then he knew that it was a worse problem that he was going to have to try and do something about.
Go back to your slide with the pledgets. Anybody else want to talk? Okay.
Thoracotomy. But when Lucas and Ledgerwood did it, they did it essentially as a way to clamp the aorta and control the blood pressure, or at least resuscitate the patient when they were going to do an exploratory laparotomy for blood loss. So it sort of evolved for that. It wasn't necessarily for penetrating cardiac injuries. It was sort of developed for a different cause, but just a historical interesting thing.
So who makes the decision about an ER thoracotomy here? I mean, surgery resident? Whoever's there. Okay, what are our criteria about, if someone comes in pulseless, what do we do?
Depends on how long down, how long CPR, and proposed mechanism.
So we
Penetrating down for a short period of time, we would open blunt. Be very hard to open unless they died in front of you.
okay. Yeah. I want to be sure we get that stuff.
Penetrating trauma down for less than 10 minutes and blunt witness arrest. We take a little bit of liberty of that just for
Right.
maximal risk.
Well, we should because it's not easy to do well. I want to make this point about two things, because this came from my own experience in ER thoracotomies, which I just happened to be on call and did a number of those as a resident. The pledgets, first of all, the silk suture, that's all we had to use in the emergency room. And after I did the first one, the only suture we had, period, had a cutting needle. That's really hard. So I got some suture and put it in a cigar box and put a drawing of a heart on it so that we had some suture that was something on a round needle. So that was a problem. But the first one I did, the patient had been arrested for a while, and hypoxic cardiac muscle won't hold a suture. And so you learn to put a pledget on it, and the pledget that I used was the part of a cotton towel because it wouldn't hold the suture, and it kept tearing a little bit. So just know that if the patient's been arrested, the points that both of them made really can't be overemphasized. Don't get in a hurry to sew it up. Give the patient time for them to become more normal in terms of their hypoxemia, and the muscle tissue will hold a suture a lot better because it responds very rapidly. So the finger in the hole is what you want to do. That's the only thing. That idea about a skin stapler is the craziest thing I've ever heard. That definitely wouldn't work, and the Foley catheter, same thing. But the pledget issue is one that, I think most of us would always want to probably use a pledget almost any time. And in this case, you got the coronary artery, I'm assuming, there over the top of it, and that's the prescribed way to do that. That's in order not to interrupt it. But the pledgets are really important. The good points all the way around. Two excellent presentations. Thank you very much. Good job.
Get your USB drive. Okay.